Last week, I told you that most age-related circulation problems are not structural. They are signaling problems. A decline in the nitric oxide your endothelium produces. And I showed you 3 specific ways to restore that signal. But I also told you there was a second problem, equally common, equally consequential, and one that the same advice, the same compression socks, the same supplements, even the nitric oxide approaches, cannot fully address on its own. It is the problem that exists even when your endothelium is working perfectly, even when your nitric oxide is healthy, even when your blood pressure reads normal on the cuff at your doctor's office. It is in the walls of your arteries themselves, not in what they produce, but in what they have become. Your large arteries are supposed to be elastic. They are supposed to expand when your heart pushes blood into them, absorb the force of that pulse, and then release it slowly, smoothing the pressure wave before it reaches the delicate small vessels in your legs and feet. That buffering is not incidental. It is one of the most important things your vascular system does. After 60, those arteries gradually stiffen, the elasticity declines, the buffering weakens, and the pressure waves that used to arrive at your legs as gentle swells begin to arrive as sharper, more forceful pulses, transmitted directly to the smallest blood vessels in your feet and calves, vessels that were never designed to absorb that kind of force. I am Dr. Mary, and today I am going to show you exactly what hardens your arteries after 60, why it matters specifically for your legs, and the interventions the research supports, including one that most people have never heard of. Physiologists have a word for the buffering function your large arteries are supposed to perform. They call it the Windkessel effect, a German engineering term from the old fire engine pumps that work the same way. In those pumps, a pressurized air chamber absorbed the jerky, pulsatile force of the hand pump and converted it into a smooth, steady stream of water. Your aorta, the large artery that receives blood directly from your heart, performs the same function. It expands to absorb each heartbeat's force and recoils between beats to maintain steady flow downstream. When arterial stiffness increases, the Windkessel effect weakens. Each heartbeat sends a sharper pressure pulse down the arterial tree. That pulse travels faster through stiffer walls, measurable as pulse wave velocity, the gold standard clinical test for arterial stiffness. And when it reaches the smaller arteries in your periphery, including your legs, it arrives with more force than a healthy, elastic system would allow. The consequence for your legs is not simply reduced blood flow, it is the wrong kind of blood flow. More pulsatile, more damaging to the small vessel walls that should be receiving a gentle, steady stream. Over time, this hyperpulsatility contributes to the same endothelial dysfunction, the same small vessel stiffening, and the same circulation impairment we covered last week. Stay with me, because the 3 causes of this stiffening matter, and understanding each one points to what can actually address it. I want to tell you about a man I will call Richard. Richard was 74. He had been following the nitric oxide approach from a video, much like the one last week, for several months. He had added dietary nitrate to his meals. He had begun a bioavailable curcumin supplement with his doctor's approval. He had changed his movement pattern to short, frequent walks. His doctor was impressed. But Richard's legs had only partially improved. The coldness was better. The afternoon heaviness remained. His circulation, while improved, still felt like it was operating through resistance, like the blood was arriving with less ease than his other improvements should have produced. When his doctor ordered a measurement of his carotid femoral pulse wave velocity, a non-invasive test that measures how fast a pressure wave travels from his aorta to his femoral artery, with higher speed indicating stiffer arteries, his reading was elevated. His arteries were stiff enough that the buffering function his aorta was supposed to provide was meaningfully impaired. The nitric oxide approach had been helping his endothelium. But the structural stiffness of his arterial walls, a separate, slower-moving problem with a different origin, had not been addressed. Richard had 2 vascular problems, not one, and the second one required a different understanding. Here is what was happening inside his arteries. and inside yours. Your arterial walls have two structural proteins that determine their elastic properties. Elastin, which allows the artery to stretch and recoil, and collagen, which provides tensile strength. In a young, healthy artery, elastin does most of the work under normal pressures. The artery stretches, absorbs the pulse, and springs back. With age, elastin fibers gradually fragment and lose their integrity. As elastin weakens, collagen increasingly takes over load-bearing responsibility. Collagen is far less extensible than elastin. It is structural rather than elastic. When collagen is the dominant protein in your arterial wall, the artery can no longer stretch and recoil with each heartbeat the way it once could. Source: arterial stiffness and vascular aging. Mechanisms, prevention, and therapy. NPJ Biomedical Innovations, 2025. DOI:10.10.1392-025-02346-0. This process is compounded by advanced glycation end products. AGES. When blood glucose rises or thinkoinfambolsten, as it does after meals and increasingly at rest in people with prediabetes or diabetes, sugar molecules bond chemically to proteins, including the collagen fibers in your arterial walls. These sugar-protein bonds create crosslinks between adjacent collagen fibers, binding them together and making the arterial wall even more rigid. Every glycation event is essentially a chemical weld in the structure of your artery wall, and these welds accumulate over decades. There is also a third component: calcium deposits. As the arterial wall remodels over years, calcium progressively infiltrates the elastin-collagen matrix, hardening it in the most literal sense. This calcification is the same process that hardens old pipes, and once established, it is the most difficult component of arterial stiffness to reverse. Understanding these three drivers, elastin fragmentation, collagen cross-linking by AGEs, and calcification, matters because different interventions target different components, and one specific nutrient plays a direct role in the calcification pathway that almost no one discusses. Stay with me, Ari, because this nutrient is the most specific and most evidence-supported intervention for the arterial calcification component of stiffness, and it is almost never mentioned in senior circulation advice. Inside your arterial walls, there is a protein called Matrix Gla Protein, MGP, whose job is to prevent calcium from depositing where it should not. MGP is essentially the calcium traffic controller of your vascular system. When it is activated, it inhibits calcification in soft tissue. When it is inactive or absent, calcium deposits accumulate in arterial walls unchecked. MGP requires vitamin K2, specifically a form called menaquinone 7, or MK7, to become activated. Without sufficient vitamin K2, MGP exists in an inactive form. It cannot bind calcium. It cannot prevent it from depositing in the arterial wall. And this inactive MGP is measurable in blood. Elevated levels of it are a biomarker that indicates both vitamin K2 insufficiency and ongoing vascular calcification. Your doctor can order this as a specific blood test. Evidence from population studies suggests that vitamin K2 insufficiency and the resulting inability to fully activate MGP is common in older adults and may be more prevalent than most people realize. The combination of dietary patterns that are often low in K2-rich fermented foods and the higher demands placed on the calcification inhibition system with advancing age means that many seniors may be running the MGP system at reduced capacity without knowing it. Source: Laurent S. Boutuiri P. Arterial Stiffness and Hypertension in the Elderly, Front Cardiovasque Medine for 2020, 7, 544302. DOI 10.3389/FCVM.2020.544302. A landmark randomized, double-blind, placebo-controlled trial published in Thrombosis and Hemostasis enrolled 244 healthy postmenopausal women, a population with known elevated arterial stiffness risk, and assigned them to 3 years of MK7 supplementation at 180 micrograms per day, or placebo. After 3 years, the MK7 group showed a significant reduction in inactive MGP levels by 50% compared to placebo, and significant improvement in arterial stiffness measures, including carotid femoral pulse wave velocity. In participants who had the highest baseline stiffness, the improvements were most pronounced. Source: Knappen, M.H. et al. Menakenone, 7. Supplementation improves arterial stiffness in healthy postmenopausal women. Throm, Hemost, 2015, 113, 5, 1000, 135-44. DOI: 10.160/TH14-08-0675. This is not a fringe finding. The MGP calcification K2 pathway is one of the most studied mechanisms in vascular calcification research, and MK7's role in activating MGP is well-established biochemistry. The clinical trial evidence in healthy postmenopausal women, the population most similar to seniors experiencing age-related arterial stiffness, is the most directly applicable research available. And there is one important additional consideration. Most vitamin K1, found in leafy greens, goes primarily to the liver, where it is used for blood clotting factors. Vitamin K2, and specifically MK7, has better bioavailability and longer half-life in the bloodstream, and preferentially reaches soft tissues, including the arterial wall. These are not interchangeable nutrients for this purpose. MK7 is the form the research supports for arterial calcification. Now, Richard. When Richard and his doctor discussed the arterial stiffness finding, 2 things were added to the approach he was already following. First, his doctor ordered a vitamin K2 status assessment, specifically the inactive Matrix Gla Protein blood test, which measures how much of this calcification prevention protein is sitting unused because insufficient K2 has reached it. Richard's levels were elevated, consistent with inadequate K2 activation. Second, he began MK7 supplementation at 180 micrograms daily, the dose used in the Knappen trial. After confirming with his doctor that it was appropriate given his full medication list, this was the critical caveat. Because MK7 activates clotting-related proteins as well as MGP, it can interact with warfarin and other anticoagulants. Richard was not on a blood thinner, so it was appropriate for him. For anyone who is, this conversation with your doctor is not optional, it is essential. He continued the dietary nitrate, the curcumin, and the movement pattern from the previous month. After 6 months, a repeat pulse wave velocity measurement showed a modest but measurable improvement in his arterial stiffness. His inactive MGP had fallen significantly. Most importantly, for his daily life, the residual heaviness that had persisted through his nitric oxide improvements began to ease, not rapidly, not completely, but in the direction that his previous approach, addressing only the signaling problem, had not been able to produce alone. 2 vascular problems, 2 complementary approaches, 1 more complete picture. Here is what to take from Richard's experience. First, and most importantly, if you take any blood thinner, warfarin, apixaban, rivaroxaban, dabigatran, or any other anticoagulant, do not add vitamin K2 to your regimen without your doctor's explicit involvement. K2 activates vitamin K-dependent clotting proteins and can affect anticoagulant dosing. This is a real and serious interaction. Second, if you do not take a blood thinner, ask your doctor whether arterial stiffness monitoring might be relevant given your age and circulation symptoms. Carotid femoral pulse wave velocity is the gold standard test, but it is not routinely ordered. Naming it specifically is what prompts the conversation. Third, if supplementation is considered after discussion with your doctor, the dose and form both matter. The Knappen trial used 180 micrograms of MK7 daily. Standard vitamin K2 supplements vary widely in form and dose. Confirm the MK7 form specifically. And here is the 4th lever, the one that does not require a supplement at all, and that addresses a driver of stiffness that K2 cannot reach, glycation. The AGE-induced collagen cross-linking that accelerates arterial stiffness is driven by blood sugar spikes, particularly the glucose peaks that occur after meals. Managing post-meal blood sugar through dietary choices reduces the rate at which new glycation crosslinks form. And the simplest, most evidence-supported dietary change for this is one most people have never tried: changing the order in which you eat your food. Research published in Diabetes Care found that eating protein and vegetables before the carbohydrate portion of a meal, rather than all together or carbohydrate first, reduced postprandial glucose excursions dramatically. The study measured the incremental area under the glucose curve, the total glucose load your blood vessels are exposed to after a meal, and found it was 73% lower when protein and vegetables were eaten first. This is not a small effect. It is a change in the order of what you eat, not in what you eat, and it requires no additional food or supplement. Source: Shukla, AP et al. Food order has a significant impact on postprandial glucose and insulin levels. Diabetes Care, 2015, 38, 7, E98 to E99. DOI:10.2337/DC15-0429. Tomorrow morning, look at your breakfast. If it starts with bread, cereal, or fruit juice, consider switching the order. Eat eggs, yogurt, or any protein source first, then add the carbohydrate. One change in the order of what you eat. That is where the AGE reduction starts, and where the structural protection of your artery walls can begin. 3 things to carry with you. 1. Arterial stiffness is a structural problem. The gradual replacement of elastic function with collagen rigidity, accelerated by AGE-induced cross-linking and calcification. Unlike nitric oxide decline, it does not respond to signaling approaches alone. It is a separate problem that requires a separate conversation. 2. Matrix Gla Protein is the body's primary inhibitor of arterial calcification, and it requires vitamin K2, specifically MK7, to be activated. Insufficient K2 leaves MGP inactive and calcification unchecked. A 3-year randomized trial in healthy postmenopausal women found that 180 micrograms of MK7 daily significantly reduced arterial stiffness compared to placebo. The caveat is absolute. This requires a doctor's involvement, particularly for anyone on anticoagulants. 3. Glycation, the bonding of glucose to arterial wall proteins, is a dietary driver of stiffness that accumulates over decades. Eating protein and vegetables before carbohydrate at each meal reduces postprandial glucose exposure by up to 73%, according to Diabetes Care research. It does not reverse what is already there, but it meaningfully slows the rate of new damage. Before I go, something for next week that changes the focus entirely. Over the last 2 videos, we have gone deep into what is happening inside your blood vessels. The nitric oxide, the stiffening, the calcification. The mechanisms are real, and the interventions are specific. But there is a question I keep coming back to, and that I have not yet addressed directly in this series. Why does one leg cramp but not the other? Why does the right calf seize at 3 a.m. while the left one sleeps undisturbed? Why do the symptoms follow a pattern that seems almost too specific to be random, but that most doctors dismiss as coincidence? The answer connects to a specific asymmetry in nerve supply that affects approximately 1 in 6 adults over 60. That is almost never diagnosed unless something more serious goes wrong, and that directly determines which leg gets the symptoms and which one does not. Next week, I name it. And if your symptoms have always been one-sided, this may be the first explanation that actually fits. Subscribe so you do not miss it. Because if today gave you a framework for what is happening inside your arteries, next week will give you a framework for why it is happening to that specific leg. I will see you then. Take care of those legs.